start, sir.
Okay.
Sir, it's 3, 2, 1. You can start, sir.
Good evening, dear friends. I'm here to discuss few emerging trends and facts regarding aspirin-free single antiplatelet therapy in ACS, post-ACS patient or patient undergoing PCI. Next slide, please. Coming to the brief history of dual antiplatelet therapy, it starts way back in 1998 in the era of in-stent restenosis. Then came first generation regulating stents. We all know that landmark Cypher and Texas stent, which launched in way back 2003, 2004. Later on came the era of thrombosis, defined as the optimal approach to lower early post-PCI thrombosis, ESC Firestorm ARC paper presented in 2006-2007, and they recognized late stent thrombosis also, and identified that risk factors for stent thrombosis was most of the time DAPT cessation. So the concept came for the prolonged period of dual antiplatelet from 3 months to 12 months. Later on came second generation DES like Zionsv, which was approved in 2008. And then came the bleeding awareness. We all know that BARC, which was presented in 2011 regarding bleeding risk, and they have recognized the importance of bleeding and variability in risk, as well as impact of bleeding over time. Nowadays, we have better and safer stent platforms, so more nuanced understanding of dual antiplatelet cessation, and we are going for experimental approaches like shorter duration of therapy as well as early withdrawal of dual antiplatelet. In ESC, ACC, HE updated guidelines in 2014 and 2016. They have recommended 6 months of dual antiplatelet therapy following regulating stent, and to reduce to 3 months if the patient has high bleeding risk. Next slide. So it's very important that one should gain reduction in ischemic events, but not in the cost of increased bleeding rates. So we have to keep balance in ischemic events as well as the bleeding risk. As we prolong the dual antiplatelet therapy, there will be reduction in ischemic events, but there is marked increase in bleeding rates also. So we have to balance between these two. Next one, please. So first alarm regarding bleeding is bad has come in 2006. They have found that adverse impacts of bleeding on prognosis in patients with acute coronary syndrome. There was marked increase in 6 months mortality. The patient have minor in comparison to major or life-threatening bleeding. In minor bleeding or no bleeding, the mortality rate found to be less than 5%, which has increased drastically up to 10 to 15% of the bleeding was major or life-threatening. Next. Again, this shows the impact of bleeding on mortality after PCI. In first 30 days, we can see here cumulative incidence of death has increased from 3.7% to 18.7% with significant p-value. And it has persisted even up to 30 days, up to 3 years. The event is markedly increased if there is major bleeding associated with dual antiplatelet therapy. Next one, please. So the no favorable net outcome of long-term dual antiplatelet therapy after complex PCI in patients with high bleeding risk was reported. In this study, they have taken the 4 groups. One was non-complex PCI, and there was no high bleeding risk. Another was complex PCI plus no high bleeding risk. Third one was non-complex PCI but high bleeding risk, and fourth group was complex PCI with high bleeding risk. And they have found that in the patients having high bleeding risk, expected of complex or non-complex PCI, short duration antiplatelet therapy was found to be better, because we all know that bleeding has drastically reduced the outcome over time and increase the mortality. Next one. So far in different clinical trials, there was a lack of uniform definitions, and we all know that impact of gastro and TME bleedings on mortality. In the TME minimal major or major bleeding, there was no risk, mortality risk was found, increased risk was found because the association of gastro bleeding with mortality persisted after multivariated adjustments, while the risk with TME bleeding did not. So this suggests that bleeding associated with clinical criteria, which was used in the gastro, is more important than assessed by laboratory criteria in the terms of outcome. So still the uniform definition is lacking for this. Next one. So in 2011 came the BARC criteria, introduction of validation of BARC criteria. We all know that it is a bleeding academic research consortium. So standardized bleeding definitions for cardiovascular clinical trials. And it has been found that there is strong association with 2-year mortality when the BARC score is 2 or more than 2, type 3 or type 5. There is a drastically increase in the long-term outcome. This number of deaths had drastically increased, with p-value found to be highly significant, less than 0.0001. Next one. This shows the evolution of dual antiplatelet therapy. We know that in 1995, with the advent of bare metal stents, it was recommended to have 4 weeks of dual antiplatelet therapy, followed by single antiplatelet therapy. Then early 2000s, introduction of first generation deaths. Then the dual antiplatelet therapy was prolonged to 3 to 6 months. Then 2006-7, with the stent thrombosis and late stent thrombosis, recommendation has come regarding 12 months of dual antiplatelet therapy. But in the recent 8 to 10 years, the entry of second generation deaths, again the second short dual antiplatelet therapy trials have come. So finding the sweet spot just like 2010 to have dual antiplatelet therapy to be shorter and avoid the long dual antiplatelet therapies. Next one. So what should be the minimum duration of dual antiplatelet therapy after PCI? We have a number of trials. We have come between 2012 to 2014, like Excellent, Prodigy, Reset, Optimize, Security, SRSAF, Italic, and they have shown that no advantage of prolonging dual antiplatelet therapy beyond 6 months in reducing thrombotic risk with contemporary deaths. Next one. It was published in JACC 2014 with meta-analysis. Next one, please. Next slide. Then 2014 came DAPT study, published in NEJM. It is a 12 or 30 months of dual antiplatelet therapy after drug-eluting stents. And patient was randomized into groups, 12 months of dual antiplatelet therapy. After 12 months, they have either continued dual antiplatelet therapy for 30 months or single platelet aspirin in the second arm. And it was studied regarding the benefit of extending dual antiplatelet therapy beyond 1 year. Next one. And their analysis, next slide, please. They have found that stent thrombosis as well as mass, which has included death, MI, and stroke, have markedly reduced in the patients having dual antiplatelet therapy for a prolonged period. But surprisingly, there was no difference in cardiovascular mortality. So this study has favored the prolonged period of dual antiplatelet therapy. But on the subgroup analysis or regarding the mortality, there was no advantage regarding cardiovascular mortality found in this study also. Next one, please. So despite large amount of data, still there is no conclusive answer on optimal dual antiplatelet therapy duration was evident. So it is basically all about the balance between the ischemia as well as hemorrhage. So therefore, an individualized approach based on ischemic versus bleeding risk assessment was the need of the hour. Then next one. A number of tools was developed for decision making for risk prediction models, Paris score, DAPT score in 2016, precise DAPT in 2017. Next one, these are the different scoring system regarding long-term and dual antiplatelet therapy has to continue or not. Next, please. Now, recently, there has been more recognition for trials that withdraw rather than aid to current treatments. It is well said by Stuart Pocock that we need clinical trials that can investigate the withdrawal of certain established medications to see whether such withdrawal induces patient benefit, harm, or no difference compared with continued medication. So the era has come to not only add on the therapy, but we have to introduce the new drugs and look for the withdrawal of old established medications regarding the efficacy as well as side effects. So it's very important that whether the current clinical trials meet the society's need. Next one, please. So the question comes, can we safely withdraw aspirin when novel, more potent P2Y12 inhibitors are used? Next one. It's very important because we have a number of novel and dual novel P2Y12 potent inhibitors. So these are the trials investigating short duration and dual antiplatelet therapy following PCI, like global leaders, STOP, DAPT, Smart Choice, Twilight, TICO. Out of this, that global leaders has included the maximum number of patients, almost about 16,000 patients. They have investigational and control group. In the investigational group, they have continued dual antiplatelet. In this clinical trials, dual antiplatelet for 1 to 12 months in different studies, and 1 to 3 months for the shorter duration, but continued the dual antiplatelet therapy in the control arm for the 12 months, followed by single aspirin. In the investigational arm, they have continued with novel P2Y12 inhibitors like ticagrelor or prasugrel. In the global leaders, they have included ticagrelor. In STOP DAPT2, prasugrel, clopidogrel. In Smart Choice, any of the three. In Twilight, they have included ticagrelor versus aspirin. In TICO, in ticagrelor, STOP DAPT2 has prasugrel or clopidogrel. So these are the different landmark trials. Few have completed, few are on the process of completion. They are giving more insight into the short dual antiplatelet therapy following PCI. Next one. The most important of these is global leaders study, which is a long-term ticagrelor monotherapy for 23 months, following 1 month dual antiplatelet therapy after PCI in complex clinical scenarios. Next slide, please. They have included about 15,991 patients with 1:1 randomization. They have included any type of lesions like left main, Safnesman graft, CTO, bifurcation, instant restenosis, etc. An unrestricted use of DES regarding number of length. They have taken biometrics DEX for by default, And in the experimental strategy, SCS or stable CAD patients all has to go with the dual antiplatelet therapy for 1 month, then ticagrelor only for the next 2 years, next 23 months, total to 2 years study. And reference study in SCS group, ticagrelor was given for 1 year, dual antiplatelet given for 1 year, then aspirin only for the next 1 year. In stable CAD group, they have considered clopidogrel in place of ticagrelor as dual antiplatelet for 1 year, followed by aspirin only for next 1 year. Next one, please. And they have found that BARC 3 or 5 bleeding up to 30 days, from 31 days to 1 year, and from 1 year to end of follow-up by clinical presentation. In SES arm, ticagrelor was found to be better than aspirin monotherapy, dual antiplatelet for 12 months, followed by aspirin monotherapy. But in the stable CAD, there was no much difference. Next one, please. Again, this shows the same thing. In SES, dual antiplatelet for 12 months, followed by aspirin only, which was the reference arm, was found to be more hazardous regarding BARC 3 or 5 bleeding in comparison to experimental arm. In the stable CD, there was no much difference. Next one, please. So there was no significant interaction between treatment effect and pre-specified subgroups throughout safety and efficacy endpoints, except for BARC 3 or 5 bleeding in SCS population that benefits from ticagrelor monotherapy, whereas stable angina does not. And ticagrelor monotherapy appear to reduce the risk of bleeding without an increase in the ischemic risk when compared with standard dual antiplatelet in SCS patients. So why is this important? It has been seen that ticagrelor monotherapy following 1 month dual antiplatelet therapy may reduce the risk of bleeding SCS patients, and it seems safe in various clinical scenarios in female, elderly, diabetics, obesity, COPD, and renal function impairment also. Next one, please. So after this trial, it has come that there has to be aspirin-free strategies in cardiovascular disease. We all know that for last 50 years, almost 48 to 50 years, aspirin has dominated regarding the management of coronary artery disease. Whether patient is stable or unstable, it is the main antiplatelet drug. Whether used in combination or not, even after the advent of clopidogrel as well as prasugrel, only the recent studies have shown that there can be aspirin-free strategies in cardiovascular disease because there are uncertainties surrounding the use of acetylsalicylic acid for secondary prevention, and 3 major arguments challenge the use of aspirin for secondary prevention in combination therapy with other antithrombotic drugs. First is the bleeding risk. We all know that there is increased risk of intracranial and extracranial bleeding, especially GI bleeding when aspirin is combined with other antithrombotic drugs. Risk reduction, the contemporary drugs favorably alter the baseline individual risk of cardiovascular events, translating the relative benefits of aspirin into smaller absolute effects, and presence of novel antithrombotics, the availability of newer compounds with potent antithrombotic efficacy could make the aspirin no longer necessary. These are the 3 major arguments which challenge aspirin use, and now it's coming the aspirin-free concept. Another major trial is Twilight ACS, which is ticagrelor with aspirin or alone in high-risk patients after coronary intervention for acute coronary syndrome. Next one. In this, next slide, please. In this, they have randomized population all over the world. They have about 11 countries with 187 sites. They have taken high-risk patients undergoing PCI, and they were treated with ticagrelor plus aspirin for 3 months. The patients which have event-free and adherent to the drugs were randomized to aspirin versus placebo and continued ticagrelor for an additional year. Next one, please. And this was measure bleeding BARC 2, 3, or 5 with the aspirin plus placebo or ticagrelor plus aspirin. Over 1 year, we can see it's highly significant difference between both them. In ticagrelor aspirin, there was 7.6% of cumulative incidence in comparison to 3.6% in placebo arm. Next one, please. But coming to the death, MI or stroke, there was no significant difference over time. So there was definitely no increased ischemic risk. Next one. Among patients with non-ST elevation ACS undergoing PCI with this and who have completed a 3-month course of dual antiplatelet therapy with ticagrelor plus aspirin, continued treatment with ticagrelor alone significantly lowers clinically relevant and measured bleeding without increasing risk for ischemic events over 1 year. So the effect of ticagrelor monotherapy with respect to bleeding and ischemic events is uniform across different levels of risk, and results are unchanged for patients presenting either with unstable angina or an STMI. And these findings were concordant with the results of the primary trial. Next. Another landmark trial is the TICO trial. It is also completed. It is a test of the ticagrelor monotherapy after 3 months of dual antiplatelet therapy improved upon ticagrelor-based 12-month dual antiplatelet therapy for SCS undergoing PCI with or stent, which is ultra-thin bioresorbable polymer sirolimus-eluting stents, in terms of net adverse clinical events combining the risk of ischemia and bleeding. Patients were randomized 1:1 fashion to the ticagrelor monotherapy group after 3 months of dual antiplatelet therapy. Another is a 12-month dual antiplatelet group. Next, within 12 months of percutaneous coronary interventions, which includes measure adverse cardiac and cerebrovascular events plus measure bleeding, which was defined with thrombolysis marker TIMI scoring. Next one. Total 3,056 patients were randomized. One is ticagrelor monotherapy after 3 months of dual antiplatelet therapy, and another group had ticagrelor-based 12-month dual antiplatelet therapy. Next, please. This was the primary outcome of NES at 12 months. 12 months clinical outcome. In ticagrelor-based 12-month dual antiplatelet therapy, there was higher risk of cumulative incidence in comparison to ticagrelor monotherapy. P-value was significant with 0.01. And there was 3-month landmark analysis that found that the graph has separated after 3 months. When both having dual antiplatelet therapy, the incidence was almost equal in both the arms. When the ticagrelor-based 12-month dual antiplatelet therapy has shown the separation of graph after 90 days, that is 3 months, and they have been widened gradually up to that has persisted up to 1 year. So there was definitely increased NAS 12 months with ticagrelor-based dual antiplatelet therapy in comparison to monotherapy with ticagrelor after 3 months. Next one. This was the measured adverse cardiac and cerebrovascular events, 12 months clinical outcome that has reflected again, same as the bleeding risk. There is dual antiplatelet therapy for 12 months. There 3.4% in comparison to 2.3, although it was not significant, but there was trends towards higher. And again, that has shown that after that graph has separated up after 6 months, that ticagrelor was dual antiplatelet therapy and monotherapy. So there was definitely nearing significant measure adverse cardiac and cardiovascular events were reported with prolonged dual antiplatelet therapy. Next one. So these are the few key learning facts from TICO trial among patients treated with or Cyrostent for SES, ticagrelor monotherapy with 3 months dual antiplatelet therapy showed a significantly lower risk of net adverse cardiac events, clinical events than currently recommended ticagrelor-based 12-month dual antiplatelet therapy, and reduced risk was mainly due to decreased bleeding, major bleeding as expected. And this finding indicate that ticagrelor monotherapy could be an optional strategy balancing both ischemic as well as bleeding risk for patients with SCS treated by ultra-thin biodegradable polymer sirolimus eluting stents. Most of the modern stents are ultra-thin stents. Next one. Previous slide, please. Next. So coming to two independent trials reaching the same conclusion, we have in these two studies with groups of patients at higher risk of ischemic outcomes, ticagrelor monotherapy after 3 months of dual therapy showed comparable ischemic outcomes. These findings indicate that ticagrelor monotherapy could be an optional strategy that balances both ischemic and bleeding risk for patients with SCS. TICO and Twilight are the two latest trial which have used latest second generation drug-eluting stents, which may have better safety and allow us to get away with less antiplatelet therapy. And definitely the use of new generation P2Y12 inhibitors, ticagrelor allows an aspirin-free antithrombotic management following coronary stenting. Next one. So these we have to go balanced with the thrombosis and bleeding trade-off, with bleeding like anemia, prior bleeding, or anticoagulation, cancer, plant surgery, renal insufficiency, and we have to balance with acute coronary syndrome, diabetes, complex PCI, prior stent thrombosis. These are the risk of ischemia. One has to be keep balance, and we have to trade off in between this. Next one. So questions comes the residual risk. When, how potent will be the antiplatelet, or just antiplatelet is important for SCS or and coronary events or something else. So we have to look for the other risk factors also, lifestyle interventions, guideline-directed medical therapy, followed by lipoproteins having residual risk targets. It is highly, we have few more potent anti-lipid drugs for residual risk lowering therapies like ezetimibe, PCSK9 inhibitors. Then one has to look for the inflammation. A number of trials are going with canakinumab, methotrexate, colchicine as a potent anti-inflammatory agent. With precision toolbox to look for HSCRP, biomarkers of inflammation, T cell and immune dysregulations. Look for the metabolic factors and therapies like SGLT2 inhibitors or GLP-1 agonist, which can target especially diabetic population, insulin resistance, obese, visceral adiposity, fatty liver. Then for the platelets, definitely extended dual antiplatelet therapy, but there is risk of bleeding. So we have to look for the platelet function testing. Pharmacogenomics can be used for that. Then anticoagulants, lower doses of rivaroxaban has shown few positive evidence regarding the future events reduction with single antiplatelet. Look for the peripheral vascular disease, prior, especially with the prior venous thrombosis events, thrombophilia, bleeding risk, coagulation biomarkers. These are the new therapy targets to tackle the residual risk after the potent complete platelet inhibition. So I can conclude here my presentation. Thank you. So it's very important that trend has come to look for the aspirin-free, go with the newer potent antiplatelet, especially after PCI or post ACS after 1 to 3 months, to reduce the bleeding risk and for favorable positive outcome. Thank you.
Sir, thank you for your nice presentation. Sir, can we wait for just 2 minutes? If any attendees have any questions, so they can ask
Sure,
us.
sure, sure.
So, sir, there is no any question and query from our attendees. So, with your permission, can we conclude the session from here?
Yeah, sure.
Sir, on behalf of Lupin, I would like to thank you for your insightful and educated talk, sir. Thank you very much for your valuable time.
Thank you.
Thank you on the attendees for taking listen. Sir, we are